So, excellent. I think we're live. Everything should be coming through. Welcome. I'm Ben Cormack. Real pleasure, honour for me to be able to do this webinar for the Pain Mastermind guys. Mark Cargila, thanks for having me on here. I know there's been some other very smart folk who've done some similar webinars, some good friends of mine. So that's really cool to be able to come and talk to you guys. Kind of pretty much going to be the same kind of routine that I generally talk about. I'm a pretty boring dude. We're going to just start to think about exercise and movement and pain. We know that these exercise is a fantastic tool to use. Not the only tool, which is important to add, but it's a fantastic tool to use for people with problems with pain. Generally very positive for rehabilitation, etc. Potentially, and I might throw a little curveball in there today, some of the ways that we think about these things maybe aren't quite settled yet. So we don't really know how exercise works for pain. And I think that's what I'm going to kind of talk about a little bit. And because we don't really know how exercise works for pain, I don't always know that we can very, very simply take the concepts that we have around exercise and physical performance and, variables such as strength and power and etc., range of movement and endurance, and take those concepts and simply port them over to the concept of therapeutic exercise. It doesn't mean that we can't, and it doesn't mean in some circumstances it's not a positive. It just means that sometimes we may need to think about other factors too, and that's kind of what I'm going to talk about. So really, where we're going to go with it, really, really simply, clinical reasoning for exercise more than just sets and reps, which kind of, I think, sums up what I want to talk about. So it's more than just sets and reps, and we need just to think about other stuff too, which is really important. Problem with the world in general is we like to be very polarized. We like to fit things in really neat little boxes, kind of you're into this or you're into that or you're into the other. I like this big thing called clinical reasoning, and it probably tells us that nothing and no singular treatment or exercise type is right for everybody. And the real thing about clinical reasoning is it's working out a little bit more what's applicable for this person at this time. So this is just delving a little bit more into thinking about clinical reasoning for exercise, which sometimes I don't think we do enough of. So the question is, can we take concepts from physical training? And this would be things like strength. And when we have strength, we have a specific rep range, and sometimes we can kind of auto-regulate that through the loads that we use and things like that. And then we look at kind of hypertrophy, which kind of traditionally 8 to 12 repetitions. And then we have a look at endurance, which is like 15 plus repetitions. And if you were to look at some of the exercise guidelines, NASM, ACSM, etc., these are very, very commonly used things. In fact, now a good friend of mine, Brad Schoenfeld, has shown a whole load of information about hypertrophy, and perhaps it's not so much to do with 8 to 12 rep range, etc. We can use lighter loads a lot or heavy load. It's sometimes some of the things we thought we knew, we don't always know. So all we have to ask is, can we take these concepts simply from physical training and port them over and just say, this is going to help someone with a kind of a pain problem? Okay, so firstly, does this imply that there's some sort of physical deficit? So, if we're going after a strength exercise rep range, your 1 to 5, heavy load, etc., then we must feel that someone is lacking in this strength that they need to create. And that's what strength is. It's creating a force against an external object. So sometimes I think to myself, does that imply that there's some sort of physical deficit? And prospectively, we don't really see that much that relates strength to pain. And if we think about things like nociception, again, I don't know why a lack of strength would create nociception. Nociception isn't the only thing that happens in pain. So we just have to ask ourselves what's going on here. So we have all these kind of, strength tests and tools that we use to assess people's strength. And then we say, oh, there's not enough strength. Or this strength is different to that strength. So we're going to do some kind of strength training. And I'm still not entirely sure how that would relate to the pain itself. But I can understand that if someone has pain, they may be likely to reduce their output of strength. And sometimes we need to come in and help people use the strength that they have got. So I don't always know if people need to get stronger. I certainly believe pain can have an effect on strength. And sometimes we have to come in and help the system delimit itself. So maybe the output of strength reduces after pain, and we need to help with that. But that again would be a physical aspect. How would that lead specifically to nociception and pain? I'm still unsure. So tendinopathy would be a great example. So often people are, you do a basic resisted test. People get pain, but they still tend to have strength. And we say, oh, okay, that might be a little bit indicative of, say, a tendinopathy, a resisted test, pain. If there was a lack of strength, we might say, oh, that's more likely to be a muscle tear, for example, would be clinical reasoning. But so for tendinopathy, you can have strength, but you have pain. So do pain and strength relate? Not sure. But we therefore, that kind of idea that we take these rep ranges and we simply put them in to these scenarios, maybe, again, how does that work with our clinical reasoning? Great example is something like Jumper's paradox. So Jumper's paradox is simply that people with patellar tendinopathy tend to be better jumpers. They create more force. So they create an increased load to the tissue. So sometimes could being stronger actually have an effect on pain? It could actually be a risk factor. So being able to run further and having more endurance may be separate from our tissue tolerance to be able to run that far. So some of these physical concepts that we have don't always link up with some of the pain concepts that we have. So sometimes we have to think about this with exercise, and that's one of the reasons why we saw the recent Iscalia paper where exercise didn't have any more benefit than just advice about training program alone, because potentially this idea of load tolerance and load to the tissue is different from the actual physical ability to generate force and something like strength. So actually tolerance and physical capacity may be two different things. And so when we look at our therapeutic exercise, are we looking to affect tolerance? Are we looking to affect a more physical deficit that these strength, hypertrophy, endurance rep ranges would fit into? So again, just throwing out some questions just to think about. So, we're just getting into a bit of thought. That's what we're doing. He's a thinking man. You can see it. Another traditional model that we have when we look at exercise therapy is the idea of mechanotransduction, providing a load to the tissue. This is kind of sensed by fibroblasts, and we get calcium signaling and autocrine and paracrine stuff going on, and, permeation of the cell membrane, and that sends signals to other to other fibroblasts floating around in the adjacent area, and they all come in and they lay down new tissue and they create a repair. And that's what fibroblasts do. They create repair of the tissue by laying down new collagen. But again, this is a concept that requires there to be damage. It requires there to be some sort of damage to the tissue that needs to be repaired. So the idea of mechanotherapy and mechanotransduction as a concept, again, can we take that beyond sprains, strains, ruptures, etc.? Where we see actual damage to the tissue and we want to realign collagen fibers, etc., etc. So again, we have to think about our current exercise concepts as being quite structurally based and not actually being related to pain and what we know about pain. And I think that's a really important thing to highlight, because are these two things synonymous with each other? Are these two things that interrelate? So again, we go back and we look at traditional rep ranges, we look at the concepts of mechanotherapy, and maybe there's just some gaps there in our exercise that doesn't always relate to some of the concepts and ideas we have around pain. So exercise and pain, again, we may see this slightly different thing. So we have great models such as Scott Dyer's tissue homeostasis model, and we see the kind of zone of supraphysiological overload, etc. But again, how does this then relate to physical concepts such as exercise and strength and endurance, etc.? This is, I don't know if this tells us that there's a physical deficit. It tells us that overload and low tolerance can lead to nociception. We don't know specifically how. We don't know whether that's, driven by inflammation. We don't know whether that's kind of, what happens within fat pads, or we don't know really quite how that works. And I don't always know that we actually know how to affect that through exercise either. The idea is we provide more load to the tissue, it becomes more load tolerant. Is that true? We don't know. Certainly the Scalia paper recently would suggest not, that the exercise didn't add more than just the concept of load management itself, so the overall load applied to the tissue. So some questions. How do we measure things like load tolerance apart from training volume? Can we take concepts such as strength and strength deficits and strength training and apply them to load tolerance of another type? So the question is load tolerance in itself specific? How do we affect that through exercise? So does strength equal load tolerance? So could you be strong? Could you be a weightlifter and be able to move lots of weight, but for another activity you're not very load tolerant? You couldn't go for a long run, for example, but that long run would require a lot less strength than that person has. Again, could a runner push loads of weight, and also, even though they've got lots of endurance within their tissues, even at a light load, are they going to be able to tolerate another load? So this idea of load tolerance is something generic rather than specific, so we can generally affect it through exercise. Don't know. I think the jury's still really, really out on this question. So again, that's just throwing out there is, what do we know? What do we think we know? And again, really, really big question that I think is important. Does one form of load have an effect on the tolerance of another form of load? So again, we don't know. So does power training have an effect on load tolerance? Well, probably, if that load tolerance has something to do with power. Does strength training have an effect on the load tolerance of running? We certainly see that potentially strength training has an effect on what happens metabolically. So certainly we see that kind of strength training has an effect on the economy of running. So is that a metabolic process? Potentially. But does it have an effect on the actual load tolerance itself? But we know that exercise does have an effect on injury, but we don't know the mechanism that works through. So strength training and even aerobic training may have an effect on injury rate, but we don't know if it's through the actual gain of the type of training that we're trying to do, the targeted aspect of performance. So there's lots and lots of questions that we have when exercise comes to pain and to these different factors. So what it doesn't mean is that, we can't apply some of these things. It's just that it's quite open. And I think sometimes we look at exercise for pain as quite a closed off thing. Just go and do this, just go and do, just kind of think about it from a traditional training perspective. Just do what you do in the gym anyway. And this may or it may not be true, So I think we can also be a bit more kind of circumspect about some of these things. So great example. So again, to do with kind of thinking about these physical deficits and pain. So Eddie spends all the weekend painting the ceiling, right? Everyone's had a patient like this. Eddie comes in and his shoulder is in terrible pain. Well, if Eddie didn't have the strength and endurance to paint the ceiling in the first place, Eddie might not develop pain from it. It's only that Eddie has the physical ability to do enough work to have an effect on the tolerance of his tissue, that we see that this is a problem. So again, this brings in to highlight this kind of capacity and pain model that seems to be about. So does Eddie just need more capacity? Well, maybe Eddie could have gone on for even longer painting his ceiling. Could that have caused an even greater problem? Don't know. I'm just thinking about it from a specific perspective. So Sally goes to the gym and she lifts weights. If you weren't actually strong enough to lift something, you'd probably either not be able to lift it, which would limit your pain problem, or you have an acute problem, as you were lifting it. But if I lift something a number of times, so as Sally does in the gym, and I cause myself to wake up the next morning in agony, I had the strength to lift the object. I just didn't have the tolerance. Again, they're two different things. So, great example, and I think often being good at something can be a risk factor. Again, so John goes back to playing tennis right over there on the right-hand side. John was pretty good at tennis. His brain remembers how to play. He has lots of skill. And to some degree, his body has some ability. It can still hit some of those shots. He can still generate power. But he doesn't have the tolerance for it. So actually, being good at something, remembering how to do something really, really well, could again be a problem for doing it. Is this a model of lack of physical capacity? So can we build that physical capacity through exercise? Do we need to build that physical capacity through exercise? Or sometimes is the activity the thing that we need to grade? So often we don't think about the graded exposure to the activity. We just think about how can we take another exercise and say, well, you need more strength, you need more endurance, you just weren't this or that or the other. And I don't know if we can truly say that. Again, it's just a different perspective. So it doesn't mean the idea of the physical concept is wrong, but it shouldn't be the only concept that we have for exercise. And we shouldn't limit ourselves to thinking in those ways. Again, with exercise, this was a great piece from Gwendolyn Jewell in the BJSM. I really like this. I use this slide all the time for teaching. And again, we see that there can be different presentations within the biopsychosocial model. We can see we can have different emphases on different aspects. So we have the bio, we have the psycho, we have the social. And it may be that we don't subgroup, but we can suggest that there are emphases placed on different dimensions of the psychosocial spectrum. So, for some people, it might be more about the biological, my hamstring strains. It might be more about my ability to generate internal tension within the muscle to deal with the external moment happening. Yes, absolutely. That might be affected by, a host of other factors, but they might be minimal. It could be that, the idea of exercise is completely psychological, and that basically what I'm trying to create is a harmonious environment for someone just to enjoy moving their bodies again and build confidence. It has very little to do with the physical capacity. They have the physical capacity. It's just enticing them back to understanding that they do have the physical capacity, that the psychological has overridden the physical. And then maybe we could look at the middle one where we have social factors. So, that someone may be, we might see that, they're over-exercising and their biological low tolerance is affected by their psychological, socially driven attitudes around exercise. So it might be that running is my stress relief. It might be I enjoy going to the running club, but that means that I find it hard to manage the biological overload. So again, all these different factors might influence my exercise prescription. So in the biological model, we may see that we want more load, that we want more, we have a physical deficit, that we can't kind of, use our bodies against an external load, and this is causing us problems. The external load being speed, gravity, or, whatever. But in other circumstances, we may see something completely different. So it could be that with someone with chronic pain, and this is the Pain Masterminds Network after all, is that my number one goal is to create positive memories of moving and exercise. We see that with people with chronic pain, a lot of them don't have decreases in actual physical ability. So fear avoidance. They've looked at fear avoidance with back pain and see that we don't have lots of physical deficit going on, that people are physically active, they just have an avoidance of one specific movement. So my number one goal is to create positive memories of moving and exercising. So it might be, we might advocate an element of hard work for some people. Other people, the exercise dosage that I use may be absolutely under the threshold of creating any kind of physical change at all, because I'm trying to minimize any kind of adverse effect that might dissuade them from moving and exercising. So it might just be the process of doing it is important, not even the process of it creating any adaptation. That I would say sometimes creating these positive memories to go on and utilize in future prediction is really, really important. And I think this fits with modern concepts such as predictive processing. I had an awesome lunch the other day with a good friend of mine, Tim Beams from the NOI group, from the Pain Performance Clinic. We had a good chat about some predictive processing, etc., which is really interesting. Again, is predictive processing relevant to a physical capacity model? Sometimes yes, sometimes no. Is a physical capacity model relevant to a scenario where some kind of processing or prediction is more important? Probably not. Again, it's about the reasoning. And if we limit ourselves to just using these physical concepts, then eventually what we end up is an inability to reason outside of those physical concepts as well. So I think it's really important that we think about that. So here are some things that we talk about with pain science. So we think about context, we think about perception, we think about emotion, we think about self-efficacy, we think about locus of control, we think about education, we think about reconceptualizing certain concepts. And if we look at exercise in a traditional format that we see laid down by exercise guidelines, etc., we miss a lot of these things. Nowhere are these mentioned. It's all just about the physical capacity model or reparation of tissue. So again, sometimes we may need to think about these people with that kind of thing going on. So I think that's really, really important. Okay, I think I hope I'm getting through there all right. Yeah, cool, right, excellent. So here are some concepts. Here are some concepts that we think about when it comes to. Here are some concepts we think about when it comes to exercise, and I think within these concepts we can think about lots of different ways of dealing with people across the biopsychosocial spectrum. So we have exposure without danger from Max Zussman, which is really nice. So again, it's what I kind of alluded to before, that what we're trying to do is just getting people back to exercising, that it's under their danger threshold. So that if we can expose it to people, we can expose it to people more and with a greater load, etc. Got the concept of stress without distress from Hans Saley, for kind of the general adaptation theory. Things like the credible evidence of safety from the NOI guys, graded exposure from Gifford, optimal loading, people like Phil Glasgow, who I think has a really good handle and concept on exercise. All these concepts, I think, are ones that we could use all across the biopsychosocial spectrum, okay? Optimal loading, I'm not really sure what it is. Again, it would probably be very individually based, okay? So these are some concepts that I think it's really, really nice to kind of think about. So again, you can think about any kind of exercise experiment that you want to do, and that may be driven by lots and lots of different factors. So what can we do? How can we fit exercise into the idea of pain science as well? And again, it doesn't have to fit into the concept of pain science. It's just for some people that might be really, really important, that the physical capacity model may not be the most relevant model. So we can think about using time rather than reps. And this is stuff that's championed by, guys like Zussman and Ionez, etc., looking at the idea that we use time. So sometimes when we look at exercise, we think about reps. Sometimes when we think about exercise for therapy, we're using the concept of how it feels. And we know that if pain is an alarm, then that alarm could be a false alarm, and it could limit our ability to go through a course of exercise. So use time rather than reps, or time rather than the way it feels. Some recent work looking at exercising in pain. Is it beneficial? Is it detrimental? And we see that there may be a small statistical effect. I don't know whether that's going to translate into a clinical effect, but certainly it tells us it's not detrimental. Okay, so maybe we think about using relevant movements, not just exercises with names, from a Romanian deadlift to an Albanian wood chop to, a Venezuelan one-legged dumbbell press, or whatever you want to call them. Exercises generally have names. They have names because they have rules. Sometimes the movements that people need to do or to exercise, they are not in the exercise repertoire. If we think about concepts around special tests, a great example would be the best special test is the movement that hurts. Well, in terms of exercise, the best exercise may be the movement that hurts but modified or adapted. They may not look like any exercise that we can find in a book or on the internet, etc. And they may be things that we need to think about. We need to think about a graded approach to activity. Again, all these people that I talked about, these little case studies, may have enough physical capacity. They may just not be tolerant to the activity that they're doing. Okay, really, really important. Exercise is often about work and tension and etc. What we know about people with lower back pain is, and people in pain in general potentially, is that, you know, sometimes they need to relax and just let their bodies flow and move and work mechanically the way they were meant to, rather than this tension and fear, etc. So these are concepts that are important. And also the idea that exercise and movement, it can be much more individualized and less generic. But that requires more clinical reasoning and thought and experimentation. And sometimes we want that fire and forget. We want that, you know, kind of just pick up this exercise and do it 10 times and in 12 weeks you'll be fine. Does that work? Sometimes. Does it work? Sometimes not. It would all depend on who you see, when you see them, how you see them, etc. Okay, and again, I think often our perceptions of what therapy is are dictated by the patient group that we see. So if we see lots of people with ACL repairs post-operative, that's going to be our idea of what rehab is, getting back strength, etc. If you see lots of people with chronic pain, then that might be about what you think rehab is. Rehab is about what the person needs and about being able to differentiate one person from another. Okay, I think that's a real key factor. This is a little infographic, or, you know, just a little PowerPoint slide that I did the other day. And it's just, I don't know if we can see that, so I've got it written down there. So how do we start to think about kind of using activity rather than specifically exercise? So we can have active listening and questioning to find out what valued activities might be. Find out the meaning that that activity might have for them, so we can address it and frame it in the right way. Set some small goals. Find a tolerable dosage. Again, the tolerable dosage in the beginning might be so far below any kind of physical change, but that might be important for minimizing any side effect, because a side effect might dissuade people from the process, and the process will get them from where they need to go. So progressively increasing at a tolerable rate. Again, the psychological side of things is very, very important in terms of highlighting gain and progress. People need that. Plan processes to facilitate adherence. Set reminders using technology. We know we've seen a number of papers recently about using technology to facilitate exercise and adherence. Educating people that pain is normal. Yeah. I think that's all really important stuff. Cool. So helping people to understand also, it can be a lengthy process of adaptations with ups and downs. Okay, so cool. So we're going to move on. We know that exercise is really, really important and cool. I think that's a key point as well. Sorry guys, just make sure that, can someone tell me that everything is okay out there? Seems like I want to make sure we haven't got any technical hitches. Just because my power monitor's gone a bit funny there. Okay, fine. That all looks good. All right, my apologies. Cool. So, exercise. We know exercise is a really, really positive thing. We can see that from a recent systematic review of exercise. This in a very reputable journal, PLOS One, the other day. And I think that's a very important thing to understand, that exercise is always a positive, and that we know it's evidence-based, research-based, etc. I don't always know if we always know the best way to do it. And again, moving away from some physical concepts as well. So really, basically, we don't know exactly how exercise works for pain yet. Each person is complex, and there are no universal answers except for reasoning. And people will be right across that biopsychosocial spectrum. So someone said, it's okay here. Perfect. My internet connection hasn't been that great recently. I don't know whether my son is watching, bad things on the internet and stopping the pipeline or whatever, but it's been a bit terrible. But if it's okay out there, it's okay in here. So just to highlight how complex it is, I'll go back one slide there. These are some of the models that we have of, human function, if you like, not just pain. But certainly we see that the neuromatrix is just a model of brain function. We have kind of the Lorimer Moseley model of, how dangerous is this really, this constant appraisal. One of my favourite models, which is the MON model, the mature organism model, and the kind of sample scrutinised respond from Louis Gifford, and then Mark Jones' movement and reasoning model as well up the top. And what these things serve to tell us is that it's more complicated than just this idea of physical deficit that we look at, certainly in terms of exercise. So when we do help people with exercise, do we actually know what we've done? So can you hand on heart say you know what has changed? So what could we have changed? We could have changed kinetics, energy flow through a tissue. So we know that running in a different way, or running from heel to a toe or toe to a heel, has an effect on where we get injured in terms of more ankle injuries or more knee injuries. So the style in which we move can have an effect. So that might be kinetics, the energy flow through a tissue. It might be the kinematics, the actual movement of the joints themselves. And some people might suggest that more as biomechanics. We could have physiology. So the wonderful paper by Ebony Rio looking at tendinopathy and pathology or pathophysiology. So is it actually damage, or is it actually a pathophysiological process? And we've got some great work by people like DeVos, and there was another guy, I think he was Austrian, I can't remember his name, and he looked at things like tenocytes as pumping out kind of genic pro-inflammatories like substance P and calcitonin gene-related peptide, and all these funky pro-inflammatory peptidergic chemicals that work through funky things like phosphorylation. They don't even need ion channels. They create ion channels opening from reactions from within the cell, and all these kind of really, really complex pathophysiological processes. Do we know whether that's changed? Certainly that when we look at things like fat pads, we see that, we don't know if it's a damage to a fat pad, but we know there are cytokines, and we know there are other kind of neuroimmune things that are floating around that can be affected by external load. Again, is it a pathophysiology? Again, it changes our idea of what maybe nociception is, or these kind of factors. So, but do we know if we've changed that? Not so much. Neurological, have we changed signalling? Have we changed interpretation of a signal? Is it cognition? Do I think about it differently? Do I feel about it differently? So just some really basic questions when it comes to exercise. Again, when we think about a physical concept, it's about, have we got stronger? Have we got this? Have we got that? And let's be honest, not a lot of people measure it. But let's ask a question. Symptom modification, if it's changed. Firstly, does it matter that we don't know the mechanism? Because we don't. So we have to ask, does it matter? Can we always measure it? Again, big question mark. Does it need to change? So what I mean by that is, if we look at a physical model, we might suggest that, something needs to change because it's obviously a deficit. But sometimes things don't need to change, but the way it feels changes. So again, this throws this curveball in behind the mechanism, and that affects us because the mechanism we're trying to change physically through exercise prescription may not be the target, what needs to change at the back end. So again, it becomes a little bit of a complex scenario. Okay, so if we think about great exercise to do with lower back pain, and what they found here was that when you exercise for lower back pain, actually we don't know what needs to change. We looked at endurance. Well, when we say we, it's a large we, not we, me, we. These guys found that, I'm trying to slide in there and claim some kind of ownership of their study. It wasn't me, I promise. Great study though. So, what these guys looked at was that, if you work on strength, does strength need to change to have a positive effect or on back pain? And the answer was no. So what's the mechanism? Again, if we don't know the mechanism, then how does that affect our exercise intervention? What we'll be looking for? Okay, I think that's a really interesting concept. So they found that with exercise tendons, so HSR, heavy slow resistance, is the kind of new big thing. Load it heavy, even though actually when you compare heavy loading and the Alfredson protocol heel drops, there was no difference. People say, well, people prefer doing HSR because the Alfredson takes a shitload of time. And you might say, I agree with that. But there's also a modified Alfredson that takes a lot less time. So actually, we should look at the HSR versus the modified Alfredson potentially, and that might, that might change the satisfaction difference that we see there. But again, so, HSR is designed to have a structural change. But we know that actually, we don't know that there needs to be a structural change for there to be a change in pain within tendinopathy. So exercise driven towards structural change might be the wrong mechanism. Again, great paper by Ebony Rio. I've always enjoyed chatting with Ebony. The pain of tendinopathy, physiological or pathophysiological. We're touching on also the kind of pathology model as well. So I think it's really important that we understand that there's some of these gaps out there with our traditional thought process. Another great paper, should we care about tendon structure? So if we don't care about tendon structure, and they're suggesting that the time course between changes within the structure and changes within the pain response are different. So they don't correlate. So we don't see a correlation relationship between the two. If you were to run a Pearson's correlation, you wouldn't get a correlation. So how does that therefore affect our exercise reasoning that goes into treating tendinopathy? And again, I think that's really, really important. So often our understanding of the problem affects our exercise reasoning. But then we also have this data on the other end that suggests that, well, actually, that kind of reasoning thought process doesn't always work out because we don't need to change that thing to get a positive response. So really, if your head's not hurting and you haven't got a big headache by now about exercise, then you probably should have, because I have. Jesus, it's all really complicated stuff. But what's most important about all this, I think, is that we understand that, it's not just simple as porting over some of these physical concepts. And again, this is the paper I was talking about before, about the HSR, the heavy slow resistance versus the eccentric training, the Alfredson protocol. And they show the results of this study show that both traditional ECs, eccentric and HSR, are equally as good. So again, we see that the kind of, when we study them together, maybe we don't see a predominant mechanism of change. Again, we see this within patellofemoral pain, that, we say, well, we should use open chain, not closed chain, not open chain, to do contact pressures, patella, etc., etc. And actually, what we find out is that, they both come out about the same. And this is a long-term study. Great paper from Eric Vitrow and also my good friend Damien Van Tigelen. Again, we look at these kind of, different mechanisms. Some people might suggest that low load motor control is better, and then high load deadlifting is better for back pain. But actually, they come out, guess what? The same. It's the same shizzle. So what does that make for the mechanism then? Because people would suggest, well, motor control, we're improving timing, variability, etc. Or we might say we're improving tissue load, or some people might say we're improving cognition about using our back. But actually, this study leads us to none of those conclusions. It might just lead us to moving is positive. Again, what does that do to our concept of exercise reasoning? What does it do to our idea of sets and reps and loads? It kind of throws it all up in the air a little bit, doesn't it? It means that maybe we need another model to suggest how this all kind of works out. Okay, again, another one. An aerobic program versus muscle strengthening program for chronic low back pain. You know what? Both worked. So what was the mechanism? And if we don't know the mechanism, how do we program? Again, does it come back to activity, just moving? Does it come back to belief structure? We just don't know. But what it asks us potentially is to be a little more individual. So if one isn't more effective than the other, it doesn't mean that one can't be more than effective than another for an individual. But that just means we need more clinical reasoning. We need to consider more dimensions when it comes to exercise rather than just tissue or physical deficit or mechanotransduction. It means we need to bring in other concepts away as well, I think. So I think that's really, really important. Okay. I don't know why I've got this in there twice. It's such a good slide. I've put it in twice. I'm sure that's an accident because I'm a bit rubbish at PowerPoint. Again, this was the paper that I talked about before from a Scullier recently, a BJSM, and I think this has probably put the cat among the pigeons a little bit amongst the PFP guys. And they had an education group, education and exercise group, an education and gait retraining group. And what they found is the exercise group increased their strength. They found the gait group improved their running mechanics. But neither of those was simply better than giving people good advice about training. So therefore, that means that the physical deficit model in terms of biomechanics potentially wasn't prevalent here. The physical capacity model in terms of strength wasn't so prevalent, but we could suggest that the low tolerance specific to the activity of running was a key driver. Again, it's a tolerance isn't a physical deficit in the same way that we can target through traditional exercise. So again, it comes back to modification of activity, etc., as another powerful way of helping people out. And again, I'm always asking, this is my big question, right? I'm always thinking about this and asking, what do I want? When I think about exercise, I'm not thinking about rep ranges first or, you need more this or you need more that. I'm thinking, is it to do with tissue capacity? And then that might lead me to the concept of you need more strength, you need more tolerance, you need more whatever, I might think about adherence with someone else, is that the exercise is just that people aren't physically active. They are sedentary, and we know that being physically active is important for health, and we know that being physically active is important for a number of different musculoskeletal conditions. And that's why when we go back to the exercise pyramid that I showed before, exercise is good for MSK pain, but we just don't know why or how. But reasoning models hopefully help us get there. So we have tissue capacity, we have adherence. It could just simply be people need to move. It's about fun, it's about preference, it's about being meaningful to the person. It's about the perception of the exercise. The sets and reps are on the floor for me. I couldn't give a shit, right? We might think about movement strategies. People with lower back pain may have some of these maladaptive movement strategies. Fear avoidance, in part, might be driven by movement strategies as well. You could say that someone who doesn't flex their spine a lot and becomes flexion intolerant, that's about movement strategies as well, and sometimes about flexing the spine more to build that tolerance. Again, these things aren't mutually exclusive because we see movement strategy and tissue capacity probably having a fairly strong relationship in some circumstances. And then we also might get belief structure. What does someone think? It might be that all these other things, adherence, movement, and tissue capacity, are secondary to how they think and feel about movement. And it might be, I don't care about sets and reps and loads. I care about finding out these factors that affect belief structure. And once I've had an effect on belief structure, then people can worry about these physical concepts as well. Again, so exercise selection. The first question you have to ask yourself is, what do we want? And again, then, why do we want it? It's like, what do we want? When do we want it? I don't want to get any kind of, marches. I know these kind of things are in the papers at the moment. I'm glad it's, over in Mark's neck of the woods over there in the US rather than all the kind of craziness in the UK at the moment. We've had our little crazy time. So when you're thinking about exercise, think to yourself, what do you want? And then this dictates how we start to think about what we're going to do. And it might not be about these sets and reps and loads, or it might be. It depends. It depends on what the answer to the question is, what do we want? And after that, we can start to adjust loads, reps, sets, time, equipment, context, behavior, all of these different factors, right? So that's that first question. And that's driven by your clinical reasoning process, your subjective history, your just subjective exam, your objective exam, etc., etc. Just doing your good job, right? Again, then we can move on further. We can think about what is the optimal load for someone. And as I said before, an optimal load might not be the most optimal. So for someone who has very low confidence exercising, The optimal load might be very, very close to their kind of boundary or tolerance to create an overload. So if we think about the basic context of creating a physical overload, we need to be somewhere, near to the mark to create that need to overload. We need a subtle overload, right? And then we get an adaptation. For someone with pain, it might be I'm shooting so far under that because I want to build adherence. I want to build confidence. And the more likely, the closer I get to something being optimal and creating this optimal overload for adaptation, the more likely I potentially could be to be problematic as well. So the ideas of optimal load are brilliant, but sometimes the optimal load and thinking about all these different ways that we can apply load to a tissue may be suboptimal to the idea of building people's confidence in terms of movement and exercise. I think that's a really important point to think about. So basically we're asking also, what is the end goal? It's the end goal isn't just strength. We might think about the end goal as being relevant to function or to life or to what this person does. And then we might think about loads and forces, durations, movement and exercises, all these different factors. So again, it's always about clinical reasoning. And I don't think we do enough needs analysis for people. We don't really think about what the end game is here or the end goal. What we're really just thinking about is, you need more strength, or you need to fire a muscle, or you need to get your glutes firing. And for me, that's very, very poor, lazy reasoning. And Roger Kerry wrote a great blog about this, saying they don't pay me enough to think. But one of the reasons I do this job is because I love thinking, I love problem solving. In any job, you're going to get guys who are, very passionate and into it, and other guys who just pick up their paycheck. Hopefully I'm one of these guys that's very thinking and very passionate, and that clinical reasoning process is always something that's driving me to think about these things. So just kind of getting to the end now. I know I go on a bit. I do apologise. Hopefully it's good information, right? Maybe Mark will ask me back. Maybe Mark won't. Maybe he'll send me a bullet in the post. I'm not sure. We'll have to see what happens. So simply when I think about exercise, I just think about what I call a constraints-based approach. And this may not always be the traditional way that we think about a constraints-based approach. It's potentially, I think it's potentially a bit of a kind of maybe a bastardization, but I think it's important. So really, I don't see that there's such a thing as a bad exercise. This guy over here, that's a stupid exercise, not a bad exercise. But we're basically thinking about internal constraints and external constraints on exercise. External constraints might be the environment that people have, the access to the gym, ability to use heavy weights, high or a low load, the equipment that we use, the body part that we use, the instructions that we give people, the stimuluses that we use, and that could be, external stimuluses that create changes in movement, etc. Time is a constraint, whether it's a task that we allow freedom and variability in, or whether it's maybe a set exercise as a set of rules. Everything is just about manipulating these subtle constraints. So rather than just thinking about, sets and reps, etc., I'm actually thinking about, well, the load that I'm going to pick up may have an effect on the amount of reps that I do. That might be a constraint within itself. An environment, if I don't have gym access, then that might stop me from doing a heavy loading program. That might be a constraint straight off the bat anyway. The equipment that we use. So a barbell will provide a very different equipment from a resistance machine. Will provide very different equipment from a band. Will provide very different stimulus from a single arm dumbbell that we use. All these different things create subtle shifts. And I find this really exciting, that we can manipulate, we can adjust, we can change shit, and that has subtle effects on people's bodies and the way that they feel. And that gives me a chance to play around. Now, a traditional model is often do these reps, bang on this, with this rest time, and it will create this effect. And I don't think we have enough freedom. When we come away from that model and just think about constraint, we manipulate so many different factors and so many different variables that we can really create individualized exercise and movement for people. And I think often we're scared of doing that. We're scared of getting it wrong. We're scared of making things worse. And I think, that might be in position, it might be in load, it might be in the type of exercise we do, the effort we use. And I think we can do better than that. I really think we can do better with that, right? Another factor on constraint might be people's fear and confidence and motivation. Motor learning history might affect how intricate they can be with things. Sensory changes within the brain, the motor cortex, we see that with relation to lower back pain, smudging, etc. Previous experience might affect the stuff on the top line, and then physical stuff might internally in our bodies may also affect what we do with exercise and movement, flexibility, fatigue, structure, strength and power. So there's all this stuff going on that we can play with. So I'm just going to finish off here. Just talking about my approach to the clinical reasoning of exercise. And first we start with the problem, right? So we always start with the problem. What is the problem? And this isn't always terminology that I would always specifically use with a patient, problem, issue, but whatever. Let's not. People make too much of a big deal about words. Words are just words. It's often the intonation that you use, right? I could say, you are, you really lack a lot of strength, buddy. Or I could say, you could just be a little bit stronger and we'd be cool. I've used the word strength, stronger, whatever, but I've used it in two different ways. So I think we get too into words. We need to think about the way that they're said and the relationship that you have with people. Words are just words. Anyway. The problem, for better or for worse. Then we're thinking about the patient's goals. Very, very important. If you don't know where you're going, how the hell are you going to get there? If you're just thinking physically, someone lacks strength, someone lacks this, someone lacks that, or you just need to do this, you just need to load it. Well, actually, the patient goal is unimportant. If you actually think about the patient goal, then it potentially affects how we get there. So I think that's really, really important. That's clinical reasoning, right? And then we have the clinical exam as well. So we have the goal and we have the exam, and it's important to do both. Clinical exams are especially important for finding out stuff if it's there and it's going to affect our process. Clinical exams are good for finding out shit that isn't there, and then how that affects our reassurance processes, etc. Always good. If you're going to get into this kind of funky, fluffy pain science shit, we should also think about being very, very good at the traditional stuff as well. Just simply because we can say we've covered our bases before we move on potentially a little bit more contemporary thinking and treatment. So we need to think about our goals now and our clinical reasoning and our best evidence. So we've got from our patient goal and our clinical exam, now we have a goal, we have what forms our clinical reasoning, and then we mix that with the best evidence that we have. Now, it's really important. I've shared a lot of best evidence about exercise with this little lecture. And again, it leads us to be quite inconclusive. A lot of best evidence and best practice is quite inconclusive. But that makes a lot of sense because people are very individual. And being individual means that there's lots of ways to skin the same cat. And actually, sometimes our biases can be upheld, sometimes they're not. Who knows? But it's important that we have a process. So it's important that we discuss our hypothesis and we inform people of what we think is going on and how we are going to reach their goal. And I think it's like pain science. It becomes much more effective when it's individualized. Things like goal setting and exercise become much more effective when people believe it directly relates to them and addresses their problem. It's not just another generic exercise like a shitty clam that you've thrown out to the past 400 people because you want to get the glutes firing. That isn't individualized therapy very well at all. So do you know what? I'm going to finish this off and then I'm going to get to some of the questions at the end. I've got some of the questions over here and I'm going to scroll down them. So we're thinking about patient preferences and expectations, very, very important. We're thinking about their belief structure about their body and exercise, and we're thinking about discussing potential barriers to the involvement of them within an exercise program. So preference might be what exercises they enjoy. Expectation might be, have they previously done exercise that hasn't worked? So it forms a negative expectation. Beliefs about structure, again, may limit adherence because they feel the exercise might do them more damage. Potential barriers might be all of those things, plus lifestyle, time constraints, etc. I think what we then finally need to do is think about and agree an individualised plan. Say, this is the plan I have formulated for you. Are you happy with that? Are you willing to involve yourself in that? Your responsibility is to do this exercise. My responsibility as your therapist is to facilitate that process, help you plan, is to facilitate the process through educating you, is to facilitate the process through changing things that don't work. And again, it's an evolving process. It's not a fire and forget. And then finally, making sure people have adequate instructions. They have the ability to regress and progress. And they have a support network. Can they ask programs? Can they ask for you to review their program? Can they come to you with problems with exercise? Can you facilitate support networks within their families? All these different factors. And for me, this is the clinical reasoning process that I go through to use exercise. And it's more about facilitating doing it and someone's perception of it, rather than worrying about sets, reps, and the best exercise. Is it a proximal exercise? Is it a local exercise? Is it a strength exercise? Most of the time, I don't believe that's that important. I think, is it reasoned for the person? Are they engaged with it? Do they believe in it? Are they able to do it? Do they feel like they want to do it? Are they enthused and supported? Do they have the ability to solve problems? Does it address their belief structures? All these things are just, really, really important, So I think, oh my God, I've got to the end of the slideshow. So what we'll do, 15:58, an hour exactly. You know what? I'm going to get good at this one day. And I'm going to go literally from 15 to 16 one day. So 1 hour. I was 3 minutes out today. Close, but no cigar. So what I'm going to do here, let me just transition my beautiful face onto the other side. I think I might need a haircut, but we won't worry about that. What I'm going to do is I'm just going to scroll through some of these questions that we got going on here. I'm glad to see at least I've got like 2 or 3 people still listening. So let's think about this going on here. So firstly, Mark highlighted that I'm going to be in Phoenix 3rd and 4th of February, so going to be stateside. Got some other shit going on as well in Europe. Got a thing in London coming up in November, and then I'm in Portugal, and then Taiwan, and then next year for you US guys, I'm going to be in February in Phoenix. April, the wonderful Karen Litzy's helped me out with something in New York, and I'm going to be in Chicago with Sandy and Sarah, and then also up in Canada with Jamie and the Massage Centre guys as well. Right, anyway, that's just me. I'm not very good at self-promotion. It might not seem that way in terms of the amount of shit that I post on Facebook, but just in terms of, going on about courses. So I just thought I will give it a go, because I obviously need to put food on the table as well. So, Prashan, he asked me, do we need any screening tests before we exercise? So, screening is hugely vague. What does that mean? Screening for what? Do I need to do something like a PAR-Q so that someone doesn't die? I would say yes. Do I need to perceive how they feel about exercise? Potentially, because it might affect the benefit that they get from it. Do I need to screen that they haven't had previous poor exercise experiences before? Absolutely. And which exercises? Do I need to screen how they move? We don't really have very much data to support that. So in the traditional sense of screening, I would suggest no. If we're looking at movement flaws or movement errors or any of these other type of things, I don't think that's that important. No, I don't. So look, let me scroll down on my phone here. Zach, are changes in underlying physiology considered specific effects due to a associated mechanism or process, or non-specific due to the fact we can only infer this clinically? So the effects of exercise are specific to exercise. So having an effect on the cardiovascular system, having an effect on the muscular system, etc. Obviously, they're not specific to a mechanism of pain, because they're not. They wouldn't only happen. So no, I would suggest that exercise is non-specific, not specific, if that makes sense. But then again, exercise is such a broad treatment. So the idea of specific and non-specific is specific comes specifically from the intervention. Non-specific can be involved with lots of different interventions. I don't know if I could specifically say exercise is an intervention for pain in the same way that a manipulation or a mobilization is. So are exercises effects specific to exercise? I would say yes, but we don't always use exercise as a treatment, so they are not specific to the treatment. So an answer to the specific, non-specific is yes and no, I believe anyway. I don't know if that really answers the question. But because, you know, you wouldn't go and get a mobilisation generally without a painful experience, but you'd go and do a whole bunch of exercise when you didn't have pain. It's not an intervention as such, is it? It's kind of an action that we can use as an intervention. I don't know if that answers your question. I don't even know if I'm right. That's just my thought process on that. How do we approach the BPS model subjectively and objectively? Well, I think objectively it's quite difficult. We do have some more... I suppose, you know, our attempt at being objective is some of these you know, questionnaires, etc. Because they're, you know, although they're subjective, they do have an objective element because, you know, we're setting some objective factors. The question is, how objective do we need to be? So if we don't need to change strength to affect strength, do I need to objectively measure strength? Sorry, if I don't need to change strength to affect pain, do I need to objectively measure strength to see if there's a change in it? Or is that just a redundant process if they're not dependent one on the other? It's quite a complex thing, I think. I think it's very difficult to kind of get into this objective subjective thing. I think, you know, movement is a subjective objective, isn't it? So we could look at it objectively as a movement, but it's very, very subjective. So I think the whole subjective objective thing I don't think these things are exclusive or independent. I think it's kind of a big clusterfuck, to be honest with you. It's a very difficult thing. I am very objectively subjectively. So you might measure something, but I'm not measuring that against other people. I maybe measure that as a measure of change for another situation. Here's an example where I may be objective. If someone could do 10 minutes of gardening and at the end of the process they could do 20 minutes, I think that is something worth measuring and highlighting. So let's make these kind of objective measurement, in that scenario, the measurement of time, let's make this something that we can highlight as a positive. Let's also make it something that is relevant to the person. I'm also thinking, can we use objective tests as something that rules things out? So often objective stuff means that I can turn around and say, well, you haven't got X or you haven't got Y. I think that's really, really important. We can highlight the fact that, you know, these things maybe aren't as problematic as they are. So Mark, you're not going to get all argumentative on me, Mark, are you? So neuromuscular, neuroimmune, neuroendocrine, psychiatric, the immune system has been an overlooked component in pain. Part of the problem, I think, with that, Mark, is we don't know what's going on internally. So do I know that it's like, here's a great example. How do I know that inflammation is neurogenic, is from muscle damage, or from whatever? So I don't know that we have peptidergic inflammation or prostaglandin-driven inflammation. How do I know? How do I know it's more the neuroimmune system or the immune system versus other less immune-driven processes? So is it important? Neuroimmune? I think it probably is. Do I know how to measure it or affect it? Not so much. So that becomes an academic debate potentially, which Facebook's great at. Doesn't always mean that we come out with some kind of clinical situation in the end. The consideration of comorbidities or other medical diagnosis and lifestyle is vital. I agree completely. So again, that forms part of your subjective or your clinical exam, that we have other factors going on, sleep and depression and all these other factors. Absolutely. Can exercise have an effect on those? Potentially. Some data suggests that exercise is good for depression. Other data suggests it doesn't have so much of an effect. But certainly if we're looking holistically, if we're looking at the biopsychosocial model, then these things are important. Not something that I'm discussing here. I am discussing the use of exercise as an intervention and the reasoning around it. What things contribute to what goes on in the human body are kind of endless, and that you would need to think about that on an individual basis. I'm not disagreeing. It's just not kind of the purview of of what we're kind of discussing. So, look, I mean, have we got any more questions? Do you people still love me? Are you still listening? I don't know. I've gone on for quite a while. I don't know if I've answered your questions specifically. There were some excellent questions. The thing about excellent questions is you don't really have binary yes or no answers. I'm not particularly smart. There's some much smarter guys than me that could probably answer them much better. But you know what? Really enjoyed it. Again, thanks for tuning in, listening. 4:10 in the UK. It means it's nearly beer o'clock. I've got a little IPA downstairs in the fridge with my name on it, and I'm going to burst in there and dive in on that at 5 o'clock. I think if you drink before 5 o'clock, you might need some kind of psychological testing. So, I've been trying to get to that 5 o'clock barrier. When you've got kids, sometimes you want to drink at about midday, but I try and stop doing that. So, yeah, thank you, and we are off.